Okay, it's 5 minutes past 3 p.m. Kampala time, according to my clock. I want to thank you all for making the time to join this Counterpoint webinar. Counterpoint is ThinkWell's signature series of webinars, and this provides us a platform for free and frank debates about questions related to the health system and how we can strengthen it. Through these honest discussions, we strive to challenge the status quo as well as paradigms, but also scrutinize new trends to assessing their merits. Please introduce yourselves in the chat as we go. And just to draw your attention that for this counterpoint, we want to dissect the question on how strategic purchasing can improve quality of primary health care. Just a recap, in 2022, ThinkWell began a systemic process to find some answers on if strategic purchasing can improve quality of primary health care. We drafted a framing paper that my colleague Cuthbert is just going to drop into the chat, but also commissioned a series of country case studies from Burkina Faso, Kenya, Philippines, and Uganda, and we shall be sharing on those today. We will also shortly take you through a framing presentation by my colleague Ileana Vilchi, and then a cross-country synthesis by another colleague, Tapley Jordan Wood, of the cross-country synthesis from those countries. We want to indulge you in an informative discussion grounded in Uganda's experience on incentivizing quality improvement by mainstreaming a results-based financing approach into the public financial management system and a drawing from our technical panel of experts. First is Dr. Sarah Biachika, who is from the Ministry of Health. Dr. Biachika is the Commissioner Health Services, Planning, Financing and Policy, and has been at the forefront of the key health financing reforms, including the scale-up as well as the institutionalization of results-based financing. Our second panelist, who is also from the Ministry of Health, is Dr. Martin Sendiona, who is a Commissioner Quality Assurance. Congratulations, Dr. Martin, upon that conferment. Recently appointed from the Standards Compliance and Patient Protection Department, who is also at the forefront of quality of care and with a new initiative of institutionalizing RBF and how quality can be measured but also improved over time. Lastly, but not least, is Dr. Elizabeth Ekochi, who is a health systems expert and consultant from the World Bank, but also a quality enthusiast who has done a lot of work on quality of care in Uganda. The World Bank has funded several RBF projects, including the nationally scaled up Government of Uganda Reproductive, Maternal and Child Health Improvement Project. After our panel, we will have an interactive discussion, inviting all of you, our audience members, to share your perspective and experiences on purchasing and quality. As we go, please use the chat function for any of these perspectives, experiences, or requests and ask for more information here and there. We will also have an opportunity to take questions from you for the panel. So please use the Q&A dialog box for any questions, as we shall pick questions from that dialog box. Anything else should go to the chat. That is not all. We also have a senior health financing advisor from the World Health Organization, Dr. Bruno Mensen, who will reflect on our findings from the framing paper, the cross-country synthesis, as well as the panel discussion to offer his reflections and key takeaways from this webinar. Karibu sana. I hope you find this session very informative and intriguing for all of you. I will now send the microphone to my colleague Ileana to start us with the framing for this webinar. Over to you, Ileana.
Thank you so much, Angela. And thank you all to all of you who have made the time to join this webinar today. Over the next 10 minutes or so, I would like to introduce you to the work that ThinkWell has been conducting on linking purchasing to quality and its governance in health systems. A couple of years ago, governments in 4 countries asked ThinkWell for support in using purchasing to incentivize quality. Specifically, the Ministry of Health in Burkina Faso wanted to modify gratuity payments based on quality scores. The Philippines National Health Insurance Agency, PhilHealth, wanted to ensure that capitation payments for its benefit package incentivize quality. In Kenya, some county governments wanted to explore linking quality scores to facility payments. And then Uganda joined this group of countries later on as there was interest in results-based financing mainstream. In addition, there is evidence that nowadays access to health services has improved. However, there are still many millions of people in low middle income countries that die of preventable conditions. And in health systems around the world, the diminishing returns of access to health services have sharpened attention to quality and how health systems function, from management and financing to supply chains and organization. In addition, governments that want to improve quality of care may look to apply financial incentives to reward facilities and providers for delivering better quality. But it's not easy to routinely measure quality. And with this in mind, ThinkWell explore pragmatic approaches, harnessing metrics that already exist that can inform strategic decisions to incentivize quality. And as a first step, ThinkWell reviewed and synthesized ideas and evidence related to quality measurement, assurance, improvements, and governance for health services and systems. Strategic purchasing and the links between purchasing and quality. And building on this framework that we've developed, we've also produced a data collection tool with the aim to provide health purchasers, but also others, a means of understanding the prevailing quality governance and measurement practices in their health system. And finally, we've worked with local research partners to apply the data collection tool, and we'll share findings from this work later today. Now, before I go and share with you the framework that we've been using for this work, let me just start with reminding everyone the definition of purchasing. Purchasing refers to the allocation of pooled funds via transfers of payments to health service providers. And purchasing includes policies and practices that determine what services and underlying inputs are funded, who is entitled to access services, which providers receive funding in exchange for delivering services, and how providers are paid. And regardless of the institutional arrangements that exist in a country, the prevailing approaches to purchasing affect service quality. Now, our approach builds on previous efforts, and we offer an enhanced framework for how purchasing can potentially build or undermine the quality of health services and efforts to improve it. First of all, this framework situates purchasing within the ecosystem of quality governance, which you can see on your screen depicted in the block dotted box on the right. In which numerous governance functions shape quality through service delivery structures, processes, outputs, and client experiences, as you can see in the blue boxes on the left. This framework also conveys the dynamic interactions among purchasing and non-purchasing functions. Refer to the curved green and gray arrows within the ecosystem. And this shows that purchasing can influence quality both directly, as shown by the straight green arrows, and indirectly, as shown by the straight black arrows, by enabling or reinforcing other quality-related governance functions. We also explicitly recognize through this framework that purchasing is part of the broader health financing system that collects and pulls revenue and is subject to public financial management rules and processes. And this view encourages purchasers to consider how other aspects of health financing can constrain or enable strategic purchasing for quality. Our framework also recognizes the importance of the context in shaping the effectiveness of purchasing for quality. The political economy, economic landscape, and the nature of the provider market all have a role in determining how purchasing policies can be implemented and their impact to quality. Now, I would like to spend a bit of time describing the direct and indirect channels by which purchasing policies can influence service quality. Let me start with the benefits policies. Purchasers may lead or they can participate in government processes to draft and update benefit policies, which define the package of services that the population covered is entitled to. And these policies also specify how service access is rationed, etc. And the quality considerations can inform what services to include in the benefit packages. For example, packages can privilege high-value services and discourage or even exclude those services that don't yield good health benefits. The packages can evolve over time to incorporate quality-enhancing technologies and phase out the services that don't meet the quality standards. And it's very important to keep in mind that packages that are misaligned with the budgets available can harm actually quality. Now, moving to the supplier policy, these are policies that govern whom health purchasers pay for services and inputs. And a key instrument here is represented by selective contracting. But in fact, not all purchasers are able or willing to be selective about providers. In any case, there are many other ways to provide service quality, and supplier policies can influence quality, particularly in the experience of care when purchasers empower members of the covered population to choose their providers, and they allow payments to follow patients. Now, moving to coverage policies, these are policies that are linked to the pooling function and determine who can access services the purchaser buys. And the main way coverage policies can influence quality is by affecting sometimes in ways that we don't want to, who can access better or worse providers. But purchasers that want to improve quality of services can communicate directly with the population covered to increase their awareness and to cultivate demand for high quality services. And finally, we have the payment policies, which dictate the basis for resource allocation or payments to providers. And we all know that there are multiple payment approaches in a country, and the extent to which they motivate or constrain provider behavior depends on many factors. So let me stop here with the description of the channels by which purchasing policies can influence service quality, and quickly introduce you to the work that ThinkWell has been doing in 4 study countries that I've mentioned earlier in the presentation. The framework that I've presented served as the foundation for a 2-stage research process that looked at quality of care governance, data availability, opportunities to strengthen links between purchasing and quality. We started with in-depth country-level research We've reviewed documents, conducted key informant interviews and focus group discussions to explore the landscape of quality governments, to identify the key actors, the existing information system in a country, and the existing links between purchasing and quality. And then we've developed a cross-synthesis to look at the broader patterns and insights. And this involved a systematic review of country reports, comparative analysis, and evaluation of the data availability across the quality domains. And throughout this entire study, we focused on the three key questions that are highlighted on the right-hand side. Who are the main actors in quality governance? What systems generate quality-related information? And what are the existing and potential links between purchasing and quality? And just to quickly introduce you to our research findings that Tapley will present next, these are structured around 5 key quality domains. First, we have quality definitions, which refer to the key aspects of the country's policies and priorities with respect to quality. Then we have provider readiness. These are the ways the health system measures providers' readiness to deliver health services. Management of care, the measures to see if providers convert inputs and services encounters into the desirable health outcomes and good positive experiences, and the utilization and outcomes. And then we have the user experience in the ways in which people and communities experience the health system. And for each domain, we looked the key terms, we've made cross-country comparison and identified data sources and explored the potential implications for purchasing mechanisms. And to make it easier to represent our findings, we've created comparative tables that use a color-coded system. The color green indicates that something is well established, yellow that is partially existent, and red it means that it's not existent. And this approach that is structured helped us to see the similarities and differences among the countries, to provide a clear overview of each country's strengths and weaknesses in health quality governance and links to purchasing. We also have individual country reports. My colleague Cuthbert can share links to those. And these concepts that I've described were explored to identify the opportunities for leveraging financial mechanisms to drive quality improvements in primary healthcare. Let me stop here and hand it over to Angela and Patrick.
Sure. Thank you so much, Ileana, for that brilliant framing. I hope we all aware of what we are getting into now that Ileana has framed for us the gist of this webinar. I will hand it over to Tapley so that he can take us through the cross-country synthesis. Over to you, Tapley.
Thank you very much. Thank you. Can you all see my screen?
Yes.
Okay, wonderful. So I have a lot to present today because this has been a very in-depth look into each of these 4 countries. And today I'm going to present an overview of the synthesis of these findings across all 4 countries. If something piques your interest, I invite you to dig deeper into the overall synthesis report, which goes deeper into these findings. And you can go even deeper than that, down into the country level reports, where there's some very good descriptions of exactly how things are currently working vis-a-vis different governance systems that regulate quality and their linkages to purchasing. So I will dive right in. So first of all, looking at quality definitions across the 4 countries, we base this on WHO's definition of quality as a standard. And how we really see that quality and how it's defined serves as a set of guiding principles for a healthcare system, influencing their policies and strategic directions. And understanding these is really crucial as we think about purchasing mechanisms and how we align those with national quality objectives and set up targeted strategies to improve healthcare service delivery across diverse set of settings. And while all countries that we looked at aligned to some degree with WHO's definition, each had tailored its approach to reflect local priorities. For example, we found that effectiveness, people-centered care, efficiency, these are all universally emphasized. However, there are notable differences in how the countries prioritize other aspects. Things such as safety, timeliness, equity, integrated care. So, for example, Burkina Faso and Kenya explicitly mentioned safety, while the Philippines and Uganda focused much more on effectiveness and desired outcomes. Moving on to provider readiness, revealed that all four countries, Burkina Faso, Kenya, the Philippines, and Uganda, have established professional regulatory bodies that oversee medical education, initial licensure of individual providers, as well as continuing professional development. However, we found that there's significant differences in how those requirements are enforced, particularly between providers that work in the public versus private sectors. Information systems for provider data exist in all the countries, but their comprehensiveness and reliability are quite different. And that presents both challenges and opportunities we see for strategic purchasing. Right now, what we've seen in these four countries is that there's limited links between purchasing and provider readiness. However, a perspective that's emerged is that there's a lot of potential to leverage these connections. So, for example, the use of provider readiness data could be used by purchasers to incentivize continuous professional development and align the health workforce with evolving healthcare needs. So moving on to facility readiness, we see a very complex landscape here. And in every country, there's multiple stakeholders involved in facility regulation and quite a lot of differences in how those licensing practices work and the enforcement of those regulations. A key finding is the limited use of this facility readiness data to incentivize quality improvement through purchasing. But there's, again, a lot of potential here. So robust standard-driven licensure, certification, accreditation processes, all of these could serve as the basis for strategic purchasing to drive quality improvements through approaches such as selective contracting or minimum standards for contract continuation. So recent developments in Kenya and the Philippines have shown some promising steps towards linking facility readiness with purchasing. Kenya has a framework that connects certification to insurance payments, while the Philippines is using accreditation or a form of accreditation for selective contracting. But despite these advancements, there's a lot of challenges. Implementing comprehensive facility readiness systems, it can be expensive, and it's not always the best and easiest way to address very specific quality issues. It can also be a challenge to find cost-effective ways to leverage that facility readiness, because putting it in place is a challenge to realize, practically speaking. Okay, moving right along to management of care. Here we looked at supervision and supportive supervision and inspections, stock management, and patient safety. So with supervision and inspections, we found that all countries have these types of systems. Kenya and the Philippines have established processes that are linked to their national health insurance, whereas Burkina Faso and Uganda face some challenges here in data collection and analysis. Stock management shows more consistency across all four countries, with all using some form of logistics management information system. And of note here was Philippines, where there's an explicit requirement for stock management in PhilHealth contracts. Most of these systems are geared towards public facilities, and there are some instances of parallel systems as well as reporting gaps. Moving on to patient safety, it's a shared priority in all 4 countries, and each has developed guidelines that focus on cleanliness, medical air tracking, and training. But the implementation seems to vary quite a bit. A key finding here is that we see potential to link these management practices overall, all 3 of these, with strategic purchasing. And, you know, particularly in this case, like Kenya has a certification level of inspections for facilities that are being brought under contract with NHIF. And the Philippines also has a healthcare facility performance assessment system that includes some of these management of care aspects. All of these are very context specific, and you know, each will need to have quite a lot of detailed tuning in order to be useful for purchasing mechanisms. Okay, moving on to utilization and outcomes. All 4 countries have established health information management systems that have population estimations, and there are varying levels of implementation of civil registration and vital statistics systems. There is a constant struggle, I think, to realize data completeness and accuracy with these types of systems. Moving on to the patient level, we found that most countries still rely heavily on paper-based records with limited adoption of EMRs or electronic medical records. The Philippines, again, is leading in this area, having standardized unique patient identifiers and mandating integrated health information systems, along with PhilHealth contracting of facilities. We found limited use of aggregate and patient-level data in strategic purchasing. But we indicated, you know, we seem to see a lot of opportunity for this. For example, like aggregate data could inform resource allocation and monitor the effects of purchasing incentives, while comprehensive patient-level data could enable more granular and targeted strategic purchasing. And then moving on to client experiences. Again, we see efforts in all 4 countries to establish some form of client experience monitoring, collecting feedback that ranges from suggestion boxes to comprehensive surveys. However, the effectiveness of these things varies quite a bit. The most robust data often comes from large-scale population-based surveys, such as demographic health surveys that are conducted every 5 years. But of course, every 5 years is not a frequency that would easily be used to really affect purchasing decisions. And I think, you know, it's not surprising then that we found limited examples that link client satisfaction to purchasing mechanisms. There is some examples that have come out of the Philippines with the healthcare provider performance assessment system, which I mentioned earlier. And that includes patient satisfaction levels in the contract renewal process. But there's generally a minimal tracking of crucial metrics like wait times or consultation durations. We think that there is potential here to tie provider payments to client satisfaction scores. That would, in theory, create really strong incentives for patient-centered care that could transform service delivery in some ways, much like we've seen in other sectors. And one that comes to mind are things like ride-hailing services, such as Uber or Grab, one of these, where that patient-centered approach seems to be, well, client-centered approach is very much driven by the very immediate satisfaction feedback that we see. A key challenge here is obviously developing these systems in a way that can effectively and efficiently, aka cheaply, collect, analyze, and then make this data available for use in a purchasing decision. And then kind of summing things up onto the overall state of purchasing. We looked at the landscape in terms of the key attributes that you see along the left-hand column of the table on the right. All 4 countries that we looked at are at different stages of establishing these different purchasing type arrangements. Kenya and the Philippines, of course, have established and growing national health insurance agencies that have contract-based purchasing from both public and private providers. Burkina Faso is also moving forward with the establishment of the gratuité scheme, which is meant to then merge on into Sinamo, a national health insurance universal scheme, which is emerging. And of course, in Uganda, we've had some real interesting debates and innovations in moving forward the national health insurance system, which again is aiming for a universal healthcare coverage. But also very interesting in Uganda has been the integration of performance-based contracting into the mainstream public financial management system that finances primary healthcare. And so it's not always a requirement to have a purchase provider split. There are ways in which to incentivize quality using within an integrated service delivery structure. We found that population coverage and provider engagement vary across these countries. And all 4 countries really do have the strategic potential with their current setups to find new ways of incentivizing quality. A key challenge here will be expand systems that provide broader population coverage and access, and then more comprehensive quality incentives to providers in order to adequately serve the needs of that broader, of the population that's brought in with that broader access. Of course, a lot of that can start with ensuring that benefit packages are evidence-based, and then that they're responsive to the actual population needs. So let's look at the overall findings and recommendations. All countries obviously have a purchasing mechanism in place, and they really do have intentions to supply providers with the necessary resources to deliver quality healthcare. But the potential to incentivize quality improvement is not always fully realized. So our recommendation here is that, let's appreciate that the most significant contribution health financing can make to PHC quality is ensuring that there's reliable and sufficient resources. Looking at quality definitions, the foundation is often really important on what you can build on top. And so having purchasing linked to your definition of quality of care is a strong way to build political support for stronger purchasing linked to quality. And so our recommendation here is that policymakers should leverage their existing quality definitions, leverage their clinical practice standards and facility licensing requirements to better inform purchasing and make it more strategic. Using financial incentives to improve quality is one that's often spoken of. And Our recommendation here with financial incentives is that we should start with what can be really practically measured, using existing tools and systems for quality-related data as well as direct measures of quality. And be very careful in consideration of unintended effects that these incentives can create. They can exacerbate inequity, they can create perverse incentives, and they can open opportunities for gaming. So designing adjustable incentives based on objective measures that clearly match quality standards, as well as making sure that providers have the ability to influence their own performance, can be really important. Moving on to measurement systems. While measurement systems exist, for quality-related data and direct measures, many suffer from duplication, incomplete coverage, disuse. Fragmentation is a real problem in this area, with short-term projects funded by donors often that reinvent previous work, and they often suffer from discrete timelines of maybe a 5-year project where they are unable to completely implement something, and they don't have real plans for sustainability. And this creates not only duplications, but gaps and parallel systems. So our recommendation here is that policymakers should focus on revitalizing and aligning existing measurement systems with their purchasing incentives to prevent the creation of parallel systems, focusing on indicators that can be accurately measured, influenced by providers, and are used at multiple levels of the system. When it comes to information technology, we've seen a lot of proliferation of systems, and that's really led to challenges in alignment, harmonization of measurement systems. And we see lots of duplication, lack of interoperability, and data that isn't always available with sufficient frequency, coverage, or accessibility. This also has the unintended consequence of creating tremendous amounts of work for providers who have to report into a lot of these systems, leading to a lot of burnout that I think, or that we see in our research here, weakening reporting frequency as well as data quality. So our recommendation is to prioritize harmonized existing measurement systems and prevent the introductions of new ones. As well as looking for ways in which to integrate the reporting of financial incentives into existing payment and accounting systems for better visibility. With this approach, you could streamline your data collection and analysis and make it easier to make those links with purchasing. On purchaser limitations, we often see in these 4 countries opportunities where there's been a lack of ability or progress towards fully leveraging the purchasing power that a purchaser has. And often that's due to resource bottlenecks, dysfunctions in other parts of the health system, or public financial management regulations that prevent the flexibility needed to modulate provider payments based on quality-related measures. And in this area, making sure that the purchaser has sufficient autonomy and corresponding accountability to really have strong mechanisms that measure service delivery outputs and quality outcomes. And the more that they can become dynamic in the purchasing of services such that provider payment mechanisms have immediate effects, the better. And there's also provider challenges, because as healthcare providers at health centers and even hospitals, they frequently face operational challenges that hinder their ability to deliver high quality care. They don't have enough resources from any one of the different streams that feeds their service delivery requirements. And oftentimes the standards they're expected to meet coupled with a lack of autonomy to use the resources that they have effectively, they find themselves in a difficult position to deliver quality. It's also true that they find themselves at the bottom of the hierarchy of information systems, where they feed in a lot of the data going up, but then they don't see their own performance data. So our recommendation here is to empower providers with appropriate decision-making authority to assess their own performance data and use that data in a way that is coupled with the autonomy to dynamically use the resources they have available to them to best meet quality standards. And I'll stop there. Thank you very much. Over to you, Angela.
Sure. Thank you so much, Tapley. From your presentation as well as Ileana's framing is a wealth of information. We have been tracking. I see questions in the chat on the choice of countries that we are looking at, but also, of course, I have a few key takeaways as we segue to the focus on Uganda. One is that we also that the purchasing link to quality of care for Uganda was weak. There's limited data collection and analysis of quality data. Of course, there's potential for aggregating this data to inform resource allocation. We've also have the opportunity to use client satisfaction scores to incentivize patient-centered care through the quality tool that Uganda has adopted to use. And one thing that stands out for me, Tapley, from your synthesis is that all countries have potential for incorporating strategic purchasing for quality. And we now want to segue into Uganda, focusing on their efforts of integrating results-based financing to incentivize for quality of care. Just to remind you, we have 3 panelists, 2 from the Ministry of Health, Dr. Sarah Biachika, who is a Commissioner Health Financing and Policy in the Ministry of Health, and Dr. Martin Sendiona, who is also a Commissioner Quality Assurance, and Dr. Elizabeth Ikocho from the World Bank, who is a health system expert as well as a quality enthusiast. So focusing in on where the opportunities are for Uganda, we would just want to do a deep dive on results-based financing, how financial incentives are being used, the measurement of quality, practicalities and costs of regular measurement, but also to wrap up on the differences between AMCHIP, which was a project, as well as the institutionalized RBF and how quality is being measured, and to say what the hope for Uganda looks like so that we can realize the potential of incorporating strategic purchasing for quality of care. I want to start off with you, Dr. Elizabeth. Could you set the stage for us by quickly outlining the World Bank's funded RBF projects, but also the government of Uganda co-financed results-based financing projects? Over to you, Elizabeth.
Oh, thank you, Angela. Thank you for inviting me on this panel. Let me first acknowledge the important fact that there have been several RBF initiatives in Uganda all the way since 2003, including those funded by the World Bank. And then also we need to understand that these are government of Uganda projects, which the government determined are important for the country, and the World Bank just supports the government technically and financially in these projects. So the most recent one was the Uganda Reproductive, Maternal and Child Health Services Improvement Project, AMCHIP in short. It was a $180 million project which ran from 2018 to 2023. Of the 180 million, about 69 was allocated to the RBF component, and most of this was expended. Other components which synergized very well with the RBF1 included strengthening reproductive, maternal, neonatal, and child and adolescent health services, RAMNCA in short, improving birth and death registration, and there was a contingency emergency fund to support the response to the COVID-19 epidemic. Okay, so when we looked at the project completion report, other studies that we commissioned along the way, and also an analysis that we did with ThinkWell, They all showed that it was broadly successful, improving uptake of key services, just looking at the quantitative aspect, but also qualitative. Now, this led to the government of Uganda deciding to mainstream the RBF approach into the existing government health financing mechanisms. So as we speak today, a modified RBF program has been mainstreamed into the government annual planning and budgeting processes. I think let me stop there just to summarize the project. Thank you.
Thank you so much, Elizabeth, and great. So that brings us to you, Dr. Sarah. I know we've had discussions elsewhere. Elizabeth has also alluded to the mainstreaming. So I would like us to get straight into the quality question. There was a desire to improve quality, but it was always clear that you would use financial incentives to support this improvement as you develop the mainstreaming approach. Is that so? Please speak through how you use these financial incentives within the mainstream approach to see that we can improve quality of care.
Oh, yes. Thank you very much, Angela, and for this. We shall start with the AMCHIP project, where we had the RBF component. And from our assessment in 2022, that was at evaluation of the quality. We found that actually there had been notable increase in the quality of scores, especially in the first years of the project, which was targeting the poorly performing local governments. So that meant that when this incentive went in, it was very much needed. And we saw that there was remarkable improvement in the quality of services, although we used qualitative research, but it showed us that there was structural improvement in structural quality, especially in the areas where the patients actually, or clients, when you assess client satisfaction, the areas they look at, for example, is availability of medical supplies and equipment. And we found that that was one of the first areas that was improved. They knew that if medicines were available, that would mean they would be getting more patients coming in, and therefore more resources are coming in. So that incentive was used to really improve on those gaps that really affect the patients directly. But our studies at the same time did not allow us to fully understand if these improvements were actually due to increase the availability of financial resources at the facility level, or on the flexibility in how these resources would be used, or was it because of the motivation? Because the incentivization had 40% of the incentives were towards the health workers in terms of their allowance or whatever they felt they needed to do the money. So the driving force, was it because they saw the more they earn, also the higher their incentive, or was it in line with the way the design of the project? But we can generally say that RBF incentives were able to improve on the quality, and the more they performed, the more they earned. So that is, in brief, what I would say.
Thank you so much, Dr. Sarah. It's
Back to
clear
you,
financial.
Angela.
Sure. Thank you so much, Dr. Sarah. It's clear the financial incentives improved quality of care as we see an improvement in quality scores over time. I want to now turn to you, Dr. Martin. Can you please help us understand the nuts and bolts of quality incentives within the new mainstreamed RBF mechanism? Please focus on how measurement of quality is done first, but also try to elaborate on whether you've developed new tools to measure quality, what are the areas of quality you're focusing on. For example, do you mainly look at structure, processes, or outcomes, but also how these tools that you're using for measurement of quality link to the other routine systems, for example, the service availability data, but also systems around provider certification, facility licensure, or other routine reporting tools. It's a heavy question, but I hope you can.
Thank you very much, Angela, and good afternoon to you all. We are happy to appreciate the opportunity given to be in this panel and discuss how we are involved in the exercise of assessing the implementation of standards in our national system, and then translate this into improving quality of services, and also getting the service providers more involved actively in what they do when they get incentivized through the process of result-based financing that has been happening in the country. The assessment we've been doing, we have a tool, we call it has Facility Quality of Care Assessment Program. It looks at the five areas, the building blocks of WHO, the human resource, the finance, the leadership and governance, and other areas. And the assessment, we've been doing this for a couple of years, looking at most facilities as widely as possible within our city, from especially the regional referral hospitals, going down to the rural facilities, and then assigning them stars according to the performance, certifying them that level. And it was a useful tool for them to appreciate the quality of services where they are and the performance, and the kind of motivating the service providers to do better. And but I think when the result-based financing came in later on, working with as Dr. Sarah explained, it also gave it a different dimension with the service providers getting some kind of reward for what the work they do. It produced better results in the different areas, especially when you look at availability of medicines and the improvement in the working environment. Some were able to do some rehabilitation, repairs, and so on and so forth. But I think more so we saw that the system was improving in that regard. So it also brought in a good element of facilities and systems appreciating good performance and areas for improvement through the assessments which are being done. And this would be used in areas of support supervision to see that they focus on areas where they need more support to improve on availability of medical equipment, to improve on availability of strengthening governance structures, the committees that we need in our systems. So it was a useful and continues to be a useful area in that regard. So the other, of course, the challenge has been having consistently to do the assessment consistently and continuously. Often in times we can do it annually throughout the whole country, but again we select a few some facilities to fit within the available resources. The partners, when they come on board, they operate in regions. It becomes more practical for us to assess more facilities in the regions and get more precise data we need to make informed decisions on improving quality of care. But largely, it's the government of Uganda that does not provide adequate resources for us to do this. Of recent, we've been able to get the funding, again, from organized purposeful effort by government to make sure that this assessment is carried out, and to do an assessment, especially for the facilities, center pause and the center trees, those more accessible facility to the community, again, which has been very useful in that way. And we hope, I think, in the future, this will be also strengthened. Effort has been made to make the assessment more efficient and less costly by digitizing the tool, and also being linked to the DHIS tool to improve the assessment and on real-time reporting and analysis of the data and use, which I think has also been a good effort in the right direction. So we have a database system which has been established within the data management system of the country, again, to facilitate reporting and the data, especially the reporting and use. And the regional-based approach is also being used now to improve access and use of data, and also strengthen capacity for supervision within the different parts of the country. So the assessment of service standards becomes a very important milestone for improving quality of services. Although it is costly, we need resources, we need capacity. We have also moved forward for self-assessments in facilities. It can be done annually, then we transfer the responsibility to a large extent to the facilities, especially the districts, the leadership in the districts, and now the regional hospitals. There are 16 in number, to work and really see that at least there is another assessment which is done in between the year, and avail the data and use it to see that you can address quality of care. I think that's what I can say for now.
Thank you so much, Dr. Martin. Clearly from your submission, it's not a new tool. It encompasses structure, processes, as well as outcomes. You've spoken through the practicalities as well as the costs of regular measurement. There's lots of donor support supporting government of Uganda, but you've also talked about the opportunities like digitizing the tool, linking it to existing systems like the DHIS tool, but also the capacity that needs to be built over time, and a move towards self-assessment. Just one follow-up question for me is, other than this tool linking to routine reporting through the DHIS tool and digitizing it, how does it link to provider certification or facility licensing?
Yeah, the tool also was modified. It had to be modified, especially for the private service providers, because of the, I think, the number especially and the capacity available. The regulatory councils been working together with our allies, the Uganda Health Federation, and this tool has been used for setting up self-assessment for these private health service providers. Awareness being created, and the results with of concurrent monitoring and verification. The results being used, we are trying to see that they can be tied to the licensure. Progressively, we are not yet there, but I think we are seeing some element of some kind of progress. And we think it's something we can carry forward and enable us to really address the issue of quality in the private sector, which we think there's still a lot to be done.
Sure.
So the tool is also this tool has also been dictated. The squeeze self-assessment quality improvement tool has been also digitized and also linked to the DHIS tool. And now we are building capacity for structures to use to have it systematically and regularly used for assessment within the private sector. And the councils, regulatory bodies are being involved for all the different categories, the medical, the allied, and also the nurses and midwifery councils in that regard.
Thank you so much, Dr. Martin, and for taking us on a ride on the practicalities of that tool. I would like to circle back to you, Dr. Sarah, still on incentives, to just elaborate for us how much the difference in terms of money does a high quality score make compared to a low quality score? When are the payments made compared to when assessments are done, but also who receives the money and what they can use this money for? Over to you, Dr. Sarah.
Yes, thank you very much. First of all, I would like to say that the RBF approach came with an increase in the total amount of funding overall across the facilities that we are benefiting, from hospital to health facility level. And also with the mainstreaming, because we started with a project, we thought that would be the end, but we see that after mainstreaming, government has also invested in this approach, which with focus on primary health care facilities. And by the end of the AMCHIP project, I have not translated this into US dollars for everybody to understand, but by using figures, we can see that at the end of AMCHIP, facilities could raise up to like 90 billion Uganda shillings in a year. And we have seen that with the mainstreaming of RBF, in the first year of financing, government provided about a third of what we are getting through the AMCHIP project, that is about 33.3 billion US dollars. But to show commitment from government, which was actually even surprising to us as Ministry of Health, but I think because it was a conditionality under the Uganda Intergovernmental Fiscal Transfer Program, Ministry of Finance was able to allocate us an additional 34 billion, making the available funds for RBF 77 billion by about 20, about 13 billion. And this is very commendable. But instead of channeling this additional financing this year, operational activities, we decided that let this money be channeled to the national medical stores. You recall earlier on I said, what were the facilities using the incentives for under AMCHIP? A good proportion was about 10% was going
Looks like we are losing you, Dr. Sarah. Dr. Sarah, it looks like we are losing you.
So instead of this money going, we said, okay, sorry.
Dr. Sarah, can I come back to you? Can I come back to you? Your connection is a little edgy. I could move to Dr. Elizabeth and then quickly circle back to you.
I back? Sorry, I don't know what happened.
Yes, we lost you when
Can
you're
you get me
saying,
now?
yes,
Sorry.
loud and clear.
Mhm.
No worries. We
Mm.
lost you at a point where
You
you're
lost
speaking through the additional money that is now coming through RBF that is going for medicines and supplies.
Okay. Yeah, and that was largely to address what we had earlier observed, that to address that area of flexibility where facilities were procuring additional funding medicines through the RBF program. So this directly, instead of going to facilities, has been channeled, and largely to increase procurement of supplies related to maternal and child health services, as well as laboratory services. So in the area of computation, unlike AMCHIP, where a threshold computation was done, under mainstreaming, this is based on absolute quality scores from the health facility quality of care assessments. So that means that the higher the quality scores, the higher the payment. But now we are not going by individual facility. We are aggregating the scores, and they are capped at local government level. Because if we went into individual facilities, it would be a tedious process. So we use the local government average score, and then within that local government, we have ceilings computed amongst facilities based on then the individual facility scores. That means that, for example, if the average score for local government A is higher than B, then the facilities in local government A get more money from the quality allocation, even if that facility score is similar to another facility in the local government, because it's a proportion of the overall local government score. So the assessments are done annually, and then we calculate the score.
We lost you again, Dr. Sarah.
Then
I
that
know
is shared across the board. On a quarter, I mean, am I back?
Yes, you are back. I think you are trying to say that the
Sorry,
assessments are done
interruption.
annually. Sorry, it's understood. Yes, they're done
Yeah, so the
annually.
annual score, yes, and then that score is used to calculate the quarterly payments that a facility receives. Unlike in previously, so the quality incentive is uniform throughout the quarters. Unlike where under AMCHIP, where the actual quality incentive was based on a quarterly quality score. Thank you.
Thank you so much, Dr. Sarah. Basically, key takeaways is your higher score results into more money. This money is kept at local government, facilities doing better, or local governments doing better in terms of quality are getting more money. The assessments are done annually, but the payments are made quarterly. Moving on to Dr. Elizabeth quickly. I know the bank has led an enormous amount of research into RBF. Can you summarize some of the findings for us, especially in terms of which elements of RBF have been most effective in terms of improving the quality of primary health care? Over to you, Dr. Elizabeth.
Sorry, I was still muted. Thank you, Angela. I was saying that our research here and also elsewhere around the world suggests that a lot of the impact of RBF comes from providing the additional money got from the incentives. I mean, what they earn from the incentives. And it's more to do with allowing them to use it flexibly. That is giving facility managers the autonomy to manage their facilities and also engage stakeholders. Sarah actually alluded to this earlier when she said that we've done research, and yes, there's positive change in both quantitative and quality outputs from these facilities, but because of the way the projects were designed and all, it's not very easy to tease out what it is. But the research elsewhere does indicate that a lot of it is due to the flexibility in facility managers being able to manage. Because even qualitatively, when we would visit, go for implementation support missions, you'd find where there are especially good leaders, where there's good leadership, you find that a lot has been done to improve the quality, both the safety aspects, the clinical aspects, so things like making sure that health workers could actually rent a place nearby so that they're available full-time, uplifting some of their buildings, buying some of the equipment. You know, they were doing all kinds of things, but where you find good managers, they would do it. Studies we have carried out indicate that during this particular RBF project, there was improvement in quality assessment processes and scores over time. And the forthcoming research that we're doing actually with ThinkWell also shows a decline in quality scores during the relatively inactive period of transitioning to the mainstream program, affirming that RBF had definitely had an impact on all the quality processes. But on the other hand, several countries have reported as a challenge the huge management support required for managing RBF centrally. And because of this, increasingly, the World Bank is supporting reforms that emphasize the direct facility financing approach. Now, if you're interested in reading deeper and broader on our research in this area, please click on the link in the chat. The report is titled Improving Effective Coverage in Health, Do Financial Incentives Work? Thank you, Angela.
Thank you so much, Elizabeth. It's a very nice segue for us to transition into panel questions or the questions that are coming from the audience. But before that, Dr. Martin, I would like you to shed some more light from your experience. And from this emerging evidence, how do you see the quality incentives of evolving over time? Could you and Dr. Sarah each give us one example of something you would like to see change to increase the effectiveness of quality incentives?
Yeah, surely. I think as we progress, we would love to see that the whole process is institutionalized and capacity is built, and we get the good outcomes out of the whole process. So we would need, I think, the certification. I believe the certification, so we need the resources to be more available, to do the assessments regularly and routinely, and also build capacity for self-assessment. And also tie it along with the certification to be done evidently, and the clients to appreciate the level of a facility in terms of quality, implementing sub-standards. What is it, step 3, 2, or what? And I think then building this into later, the accreditation system would love to have, especially as we look forward for the insurance scheme in the future to be available. So I think it's one of the elements, the issue of recognizing and appreciating service delivery within our systems is still also lacking. We need it more evident. Regular use of the data we generate being made available, first of all, in the first place, we make it available, and we use it and to make decisions to address gaps in the areas. And there's now the supervision we do currently, there's a lot of involvement of the top leadership, and I think it is something we would need a lot in the future for this to work better, to address the gaps. The participation of leaders at all levels, not only at the center, but at all levels, they participate and they be part of the solutions for the many areas that need improvement, that we are familiar, that are happening in our systems There's also the issue of attitude. I think the many challenges have made many of the service providers, especially, think that things maybe cannot change. They take things for granted. So I think this element of, especially the leadership participating and being strengthened in its operations can make things better, much better with this incentivization and assessment for service standards implementation in our system. I think that's how I can put it.
Sure. Sure. Thank you so much, Dr. Martin. We are not doing so well on time. I have a question for Dr. Sarah from the audience. I think I will prioritize that. Dr. Sarah, you talked about absolute quality scores. The more a facility scores, the more the money they get. So there is a question from the audience here where they're saying in many countries, poorer places tend to have the weaker providers when purchasing for quality channel funds to better resourced areas of providers. How are we catering for equity? Dr. Sarah.
RBF is not the only source of financing. So what has happened is that input-based financing, which is over 60% of the financing for primary health care, factors in the aspects of equity and other indicators like infant mortality, hard-to-reach indicators, population. So we have an equity formula that we apply to ensure that all facilities at least meet the minimum standards of care. And also, as you know, the biggest component of financing for health is for human resource. So we are also ensuring that, working towards that, all health facilities or all health local governments do not have less than 75% of the staffing levels. And through the years, there have been incremental increase in wage for those local governments that have low staffing levels. So we take that into consideration so that there is financing to ensure that all facilities provide the minimum level of care. They all have at least meet the minimum level of staffing levels. And then we apply results-based financing as a way of encouraging them to improve better. I mean, to improve on service delivery and issues of efficiency. Thank you.
Thank you so much, Dr. Sarah. You may not see the people clapping. I hear them clapping for this panel. Thank you, Dr. Elizabeth. Thank you, Dr. Martin, for always joining us. It has been a great discussion. I would like now to pivot to Dr. Bruno. You have been listening in from the framing presentation, the cross-country synthesis, but also just to pick your mind, what is that one thing that you're learning from the Uganda experience on purchasing for quality that you would maybe take to the other countries, or you would like to reflect on in addition to the other reflections you have? Over to you, Dr. Bruno.
Thank you, Angela. So that was a really great session, and I really enjoyed listening to all of you, and I learned a lot. This brought me back to some of the discussions we had more than 20 years ago in Rwanda, where we were designing performance-based financing. And actually, the question which was raised by this session, should we pay for quality, was a question we raised there and we discussed. And if you go back to some of my first paper, actually, in 2006, I was not so much positive about the idea of paying for quality. But the Rwandan colleagues working in the Ministry of Health, they say, no, Bruno, you know, we have a big problem with quality of care, even if we will not solve all the problems by with with quality checklist, at least we will signal to the health facilities that quality should be a priority. And I think that's one of the messages, is that we have to keep in mind that we are strengthening health system, and we need to take a dynamic perspective at that and accept that it's not about finding the perfect solution which will stay for a long time. It's to accept that we try to build things, we adopt solutions, and then we identify their strengths and their weaknesses, and we improve them. And this was brought, for instance, by Dr. Martin, I think, where you mentioned, or a colleague of you mentioned that, for instance, in Uganda, you will check the quality once a year now, and instead of checking it every quarter. And I think it's a good move, I think, because we know that this quality verification can be quite heavy and expensive. So you probably reduce the transaction cost, but still you activate the main mechanism, which is to remind to the staff that quality matters. Of course, we have problems with measuring quality. We know that this checklist, they focus very much on inputs, for instance, the availability, the readiness, as you mentioned, of the facility. But we have to acknowledge that in countries probably like Uganda or Burkina Faso, this is still the main issue, is to make sure that the facility has the medicines, the equipment, the staff, and water, for instance, in some cases. So, of course, at some stage, the system will have to evolve to address the new problems. But I think it's on the way. So I heard very, very good ideas there. I listened also to the first presentations by Iliana, advocating for taking a systematic view to improvement of quality of care and recognizing that purchasing address quality of care through different ways. And I fully support that view. I think that within the PBF community, we have been sometimes too focused on the checklist. We thought that the checklist was the way to address quality. And as it was said, I think by Sarah, it's not only that, of course, the way the resources arrive to the facilities through the output-based payment of the PBF, but also through the input-based financing by the allocation of staff. All these mechanisms contribute to quality of care. And sometimes it's mainly the money arriving to the facility which will indeed allow the facilities to make the improvement. So I think that in some countries, there have been overinvestment in the checklist, always trying to increase it with adding indicators. And I think sometimes it would be better to have a shorter list of indicators and making sure that people focus on it. So then it leads a bit me to discuss about Tapley presentations, who identify a few recommendations from the key country review. And he made a plea for us to use more existing data. I think it's indeed something we would like. I think we have to acknowledge that in some countries there are big issues with existing database on quality. So how could we indeed schemes like RBF maybe leverage an improvement of the quality of the data? It's obvious with private sector providers where we have less, let's say, which get less support than public facilities, because Tapley has not mentioned it, but obviously there are many mechanisms for improving the quality in the public sector, the training workshops, the supervisions, and so even the quarterly meeting at district office and so on. So and we know that private providers are probably, at least private for profit, are out of the scope of this support. So yes, we could try to leverage existing data. Many of the recommendations coming from the country review are consistent with last year. We organized a Delphi survey, and our concern was to understand how to pay for quality chronic care. So as you know, all our countries have to handle a growing burden of NCDs and chronic conditions, and these raise very specific issues in terms of quality care. And so we organized a Delphi survey with experts from around the world, experts on NCDs, but also health financing experts, PBF experts, among others. And the recommendations were very consistent with those we heard from the 4 country case studies. For instance, they said the priority is to make sure that these facilities have the qualified staff, the medicines, the diagnosis test, and so on. So, but they recommended also maybe some specific provider payment. You know that there is attention now, for instance, for capitation. Capitation makes a lot of sense for chronic patients. So yes, so I think the point is that we have to accept that we have to develop understanding of what I would call a dynamic view of health financing. So how do we make it evolving? Not be satisfied with a situation and say, oh, I have now the perfect model, I don't touch it. No, I think we have to always update it and bring the next improvement. And I feel that this is what's going on in Uganda. And I really understood also from the presentation and this session organized by ThinkWell that ThinkWell is very committed to this permanent upgrade of solutions. So there is no truth. The only truth is that we have to commit to improve things and always. And as you said, several of you mentioned, we need these leaders, these champions of quality of care, either like Elizabeth, Sarah, or Martin at global or country level, but also in each health facility. We have to have this change managers committed to quality of care, and we have to support them in their undertaking. So thanks a lot for this session. I really enjoy it. I hope that other participants learn as much as myself, and we really value this contribution. Thank you.
Thank you so much, Bruno. I love the dynamic view of health financing. We need to keep improving, keep moving, but also we need these champions. This brings us to the end of this interesting session. All the links to the studies we have been referencing, either by the World Bank, ThinkWell, or Ministry of Health, have been shared. The audio recording as well as the presentations are going to be uploaded on the ThinkWell website. And until the next Counterpoint, please follow us on our socials. Thank you all for joining, and thank you panelists and presenters. It was a great session. Thank you all.
Thanks a lot.
Thank you.
Ciao.
Thank you, Angela. Thank you, everyone.
Thank you all.
Thank you, everyone. Nice discussion.
Okay.